Thank you, Sonia, for the introduction. It's great to be speaking to you all today from, and I'm currently at a rural practice in Clare in South Australia, where I've worked for many years. It's a pleasure to be talking with colleagues from other rural-based practices from all over Western Australia. I understand that some of you work in some of the most remote locations in Australia, and it's great to be able to get this type of education and information out to you. I didn't quite hear Sonia's introduction, so just to clarify, I'm now working for an accounting firm called Bretnall's SA, and I head up their Medical and Allied Health division. Bretnall's SA has established a particular focus on working with medical and allied health clients, and in my role I provide a range of practice management consultancy services for private practices, not-for-profit and government agencies. I also have the privilege of being the National President for the Australian Association of Practice Management. But that's enough about me. Throughout this webinar, I'll try and keep track of any questions you might ask using the chat facility, and Sonia will help me with that. I hope to have a little bit of time at the end to answer any questions as well. So, the Medicare turmoil. In the past 12 months has heralded one of the most politically tumultuous times in modern history since the introduction of Medicare. I'm sure you've all been aware of the changes as the battle in the media has progressed over the last 12 months. The political storm over the proposed changes to Medicare demonstrates the volatility of our industry and that practices are vulnerable to any changes to Medicare. The government's telling us that Medicare is not sustainable, and this turmoil has really been the catalyst for many practices to review their financial position and to consider whether their business model is sustainable in the future. The focus of this webinar series is to provide you with an overview of the critical issues for ensuring the financial sustainability of your practices. So let's have a quick look back over the last 12 months, what happened in terms of Medicare. I think you remember over 12 months ago in the May budget they announced the $7 co-payment measure, and we're all trying to work out how that was going to actually work in practice. By December, the co-payment measure was dumped, and they brought in 3 different other measures. The level A and B time adjustment, they were trying to change that from 6 to 10 minutes, and then continuing with a $5 reduction of rebates for patients of non-concession adults. And they also brought in an indexation freeze covering the next 4 years until 2018. Moving on to early January, and there was enough pressure for the government to then have to dump their level A and B time adjustment measure, and by March the $5 reduction in rebates was also dumped. The red line there is the indexation of Medicare fees over time, and you can see that that has steadily grown, and on average the Medicare fees have been indexed around 2% every year. The next line there is on the green line is CPI indexation, and so that is an indication of the general cost of services and basically cost of living, demonstrating that that's increased significantly higher than Medicare is indexed. The pink line there is the AMA indexation, and so what the AMA does each year is creates a schedule of fees that they recommend that practitioners should be applying for the services that they provide, and they recognise the difference between the level that Medicare is indexed at and the level it needs to be indexed for practitioners to maintain a viable growth in their business. And the blue line there is average weekly earnings. So that's demonstrating that on average our weekly earnings as Australians has gone up at a higher rate than CPI, and potentially demonstrates that that patients have the capacity, if they can afford to pay for their health care. If we consider the current rebate for, say, an item 23, that rebate is $37.05 compared to the AMA recommended fee of $75 for the equivalent consultation. So you can see the dramatic gap that has occurred over time with the failure for Medicare to keep pace with either CPI or their average weekly earnings. So basically, again, in summary, it demonstrates that costs are going up at a higher rate than Medicare revenue. It demonstrates that people's wages have gone up at a higher rate and they do have the capacity to pay. And the AMA fees really indicate what practitioners should be getting to ensure that they have strong business growth like any other business would be expected to achieve. The problem with the AMA's position, though, is that they don't take into account the patient's expectations of what they should pay for their health care. And as we know, that a lot of patients actually feel that they should get free health care. The practices that really rely heavily on Medicare revenue are really not able to achieve the growth that's required to maintain a profit that is at acceptable levels, and I'll explain a bit more about that later. What I'm going to do now is run a little poll. I'll have to see how this goes, so bear with me. I'll just put up a poll. What I want to know is what type of billing does your practice offer? So if I launch this poll, you should be able to select from your practice what type of billing you offer. Private billing, bulk billing 100%, or mixed. Or if you don't know, you don't know. So if you could indicate, that would be great. Just a couple more to put in their choice. Now, how do I do this? Do I close? I think I closed that. So I'll close that. And share it. So that's sharing the poll's results. Problem is that's not sharing them with me. So hopefully that's useful information for you guys. I was interested in knowing how your practices work. But we'll move on. This slide here demonstrates the impact of government policy on Medicare bulk billing rates over time. The Medicare system was introduced by the Hawke government in 1984. For some of us, that seems like a long time ago. It was as a means of providing universal access to healthcare for all Australians. And the graph shows that bulk billing rates have increased through the 90s, but then declined dramatically after the year 2000. It's interesting that this decline in bulk billing rates was followed the introduction of the Practice Incentive Program in 1998, and then the Enhanced Primary Health Care Initiatives and Health Assessment items in 1999. So obviously practitioners were feeling like they still needed to be generating more income, even with the introduction of those incentives. It's ironic that it was Tony Abbott as the health minister in the Howard government, who actually increased the Medicare rebate from 85% to 100% of the scheduled fees for general practices for general practice services, in 2004. And you can see on the graph that this action immediately resulted in a significant increase in the rate of bulk billing. The bulk billing rates continued to climb after the introduction of the bulk billing rebate incentives in 2005. 10 years later, we're now being told that Medicare is not sustainable, and with 80% plus rates of bulk billing nationally. It's interesting to look back over the 30-year period since the introduction of Medicare, and we have experienced some significant changes in the industry. The percentage of doctors who are choosing to go into general practice has declined, and because they can receive higher remuneration as specialists. For the rural medical workforce, as you guys well know, has been in crisis for many years and propped up by IMGs. The cost of employing GPs... I'm not sure if
you can hear me.
Yes.
Sorry, it's Sonia here. We're not getting the next slide. We're still on the quick poll.
Ah, okay. Now, how would I get rid of that? Does that work?
No, we've just got, oh, here we're on a different slide now. The bulk billing proportion now.
Yes.
Okay. That's fine.
Okay.
Yeah,
can you see that clearly now?
Yes, I can.
Yep.
Sorry to disturb
you. Right. That's all right. Sorry about that little mishap with the poll. We thought it looks like a good idea, but it didn't work out too well.
I think what it is that each individual has to open the box for poll, and that wasn't really very clear because you literally can't do it from the screen. You have to actually go into the box.
Ah,
so
okay.
That's what's happened there as well.
Okay.
But that's okay.
So hopefully, yes. Hopefully everyone can see that that chart now, and so you can see on there the bulk billing rates over time from 1989 through to 2013, and they increased up to about 80%. The PIP and EPC items came in at 98 and 99, and then we saw a dramatic drop in bulk billing rates, and then you can see when the 100% rebate for general practice services came in 2004, the bulk billing rates started to increase, and the bulk billing incentive in 2005 has also added to that increase in rates. So now we have over 80% bulk billing rates, where the government's saying now that it's unsustainable, but in some respects they created the problem. I think I was just going through some of the impact over 30 years of Medicare, and one of the main things I found interesting that the cost of employing GPs has also increased, and 30 years ago, from what I'm told, that GPs were paid about 40 to 45% of their billings, compared to current rates are averaging around 60 to 70%. We know that practice costs have also increased, and that the next generation of doctors, GPs coming out, are really not as interested in owning practices, and hence we have seen an influx of corporate business practices and existing practices being taken over by the corporates. So the industry has changed significantly, and the changes to Medicare, you can see from this diagram, subtle changes can make a big difference to the viability of what's happening for practices and how confident they are in their future. The key question is whether your practice has a sustainable business model, considering these changes in the industry, and given the government's determination to address the sustainability of Medicare. So are your bulk billing rates too high? Are your fees set appropriately and competitively? Are your costs on a par with the rest of the industry? Is your business model sustainable? We will look at all of these issues over the course of the next 3 webinars. Underlying, I guess, the whole issue of fees and the costs of services for medical services for patients is a philosophical debate. It really lies at the heart of the pricing policy for medical practices, because as medical practices we're constantly battling conflicting values of, do we make a profit, or is our responsibility about providing a service to the community? Medical practices have to make a profit, well, private ones do anyway, but they also need to take into account their responsibility to serve the community. This is a constant dilemma that exists when practices consider their fees and whether to increase them and by how much. And I think if you've been involved with that discussion about how to set your fees, you will know that that's the dynamic that you're constantly dealing with. Practitioners are really conscious of their community obligations, and that is often what distinguishes medical practices from other types of private businesses. These values reflect the dominant political perspectives in our world. A socialist view highly values the universality of our healthcare system. The socialist view believes that in providing access for everyone, that it is a fundamental philosophy. That is the fundamental philosophy behind the construct of Medicare. It reflects our values of providing a service to the community and the rights of all Australians to have accessible and affordable access to healthcare. This is the message that has been pervading our culture for years, since the introduction of Medicare, so much so that people equate Medicare with free healthcare and expect that medical services should be free. The co-payment measure and the proposed $5 reduction of rebates was seen by many as fracturing that universality of Medicare, and that's why there was sufficient political leverage to put pressure on the government to dump these measures. The capitalist view, on the other hand, believes in market forces determining fairness. This mindset believes that in a user pays approach, that it's fairer for a user to pay than to tax the entire population. The belief is that people put a higher value on what they have to pay for, and that practitioners are really undervaluing themselves by not putting a price on the services that they provide. The capitalist perspective is that profit is actually a good thing, that there is an imperative to generate a healthy profit to maintain the viability of the business. And especially in rural areas, I guess it's important for potential recruits, practitioners who are looking to come to your practice to realise that it is a financially profitable business. It's harder to recruit doctors if you're not able to demonstrate that they're going to generate sufficient remuneration. Considering the socialist perspective and the capitalist perspective, there isn't a right or wrong. There isn't in favouring either of these perspectives. It really comes back to our attitudes and our own personal values, and as GPs or practice managers, we need to be aware of these values and the forces that they play when we are having discussions and considering decisions about fees. Aside from the philosophical issues, we also need to consider the economic realities. Over 80% of GP services across Australia are bulk billed. Is that really sustainable? Is it sustainable for Medicare? Is it sustainable for the practices that are bulk billing? The decision, I guess, as to whether or not you bulk bill or privately bill is often dependent on a lot of different factors, and the most common factors I've listed here. Your location, whether you're located in a rural or urban area, a metropolitan area, in a city, will have a significant impact on that decision. The socio-economics of the community you service also has a big impact. Competition, whether you're a solo practice in a town, you don't have to worry so much about competition, but if you're in a town where there are several practices and a low socioeconomic environment, you certainly do have to worry about competition. Demand is also there. Most practices have higher demand than they can meet, and that makes an influence. And specialty type is also a factor. If you're going to provide any specialist services, the potential to actually charge for those services, because patients don't tend to expect to get those special type services for free. And finally, the financial objectives. The financial objectives of the principles of the practice really should drive some of the decision making about fees and the fees policy of the practice. As I said, in rural practices in small communities without any neighbouring competitions, you may not have to have the same price pressures as metropolitan practices do in socially disadvantaged suburbs, and I'll give you an example of that later. It's important, though, for all of practices, whether you're in rural areas or in metropolitan, to really understand these factors and the impact that they make on your decisions about fees. But really, the statistics are actually telling us that only 20% of patients will choose a practitioner based on fees alone. So what are the factors that influence their decision? What is the 80% that patients actually take into account when they're choosing a practice? I recognise that in some of your communities, your practice might be the only option for patients within hundreds of kilometres. But it's still worth taking into account what the 80% factors are, because they will be the difference between your patients just accessing your practice because it's the only one there, or whether they truly value your practice and the services you provide. In situations where you do have neighbouring competition, that 80% is crucial for you understanding and how you are placed to attract patients to your practice. So why do patients choose to come to your practice instead of another? In marketing terms, we think about it as a point of difference. What is it that distinguishes your practice from the competition? The quality of the service provided is the key point of difference, and from our experience is that patients are actually willing to pay for quality. These are the factors that are of prime concern to patients. How available is their doctor? And we know that's more challenging when we've got doctors who are working more and more part-time. What are the perceptions of your doctor's skills and competence? How well does your doctor communicate with the patients? Are they professionally reliable? When they say they're going to do something, do they do it? How well is your practice organised? Are the people in your practice empathetic towards the patient? Are they professional and friendly to all your patients? These are the elements for which patients assess the quality of the service that you provide. The question is, are people willing to pay for that level of quality? And I think they are. The other part of quality is looking at the quality of our facilities. And then patients, when they come to visit your practice, will leave your practice with a perception of the experience that they have had, and that is highly influenced by the environment and the facilities that are available. If you think of it in terms of the waiting room experience and the consulting room experience, what is it that the practice is projecting when people are in those areas? Things like making sure it's uncluttered and streamlined and professionally run with computerization. All of those things make it an impression on patients. It's also worth keeping in mind that patients are more often than not spend more time in your waiting room than in the consulting room. So their experience within that consulting room does have a significant impact on how they perceive your practice. What are the facilities like in your practice? what is the image that those facilities project to your patients? And from a patient's point of view, what are the benefits do they perceive that they receive from the fees that they are paying to you? The last critical point about patients' choice, the 80% of what patients choose, is about location and ease of access. Patients are looking for convenience and willing to pay for it. And this is probably more of a point, especially in metropolitan areas, the ability to access a service in an efficient and timely manner. In rural practices don't often have the choice regarding their location, but it's still worth considering for you, is there anything that you can do to make your practice more accessible to the community you serve? So I hope you can appreciate that the quality of a service, the quality of the facilities, the accessibility and convenience of the practice is known to have a greater influence on patients' choice of a practice rather than simply the cost of attending. And I think an example of the practices in northern suburbs of Adelaide, the majority of them are bulk billing practices, 100% bulk billing, because they're in quite a low socio-economic area, and they fear that patients will leave if they charge a co-payment. At the same time, they're concerned that they have too much demand, too many patients and not enough doctors. They're now very concerned about the impact of the Medicare freeze. If they had more faith, though, in the quality of the service they provide, they should be able to confidently apply, maybe a reasonable co-payment for patients who can afford to pay, and significantly increase the viability of their practice. The problem is, because of the competition, no practice is willing to make the first move. And we see that's the challenge we see a lot. So there's a lot of practices even in the heart of Sydney, areas that are more affluent, that are all still bulk billing because of that issue of competition. However, this indexation freeze is causing practices to reconsider their position and whether or not that that the way they charge their fees is viable in the future. And before we really consider the freeze, the impact of indexation freeze, let's consider the challenges that actually existed when indexation was in place. As we know that the normal practice for the government was to index rates annually each year, and this is happening now in July. Historically, the indexation had been approximately 2%, depending on a variety of economic factors. This level of indexing historically has certainly provided challenges for GPs maintaining what one could argue to be a minimum level of growth from year to year, and we'd suggest that minimum level would be about 3%. So most people have, over the last few years, if they've had their wages increased over time, would have had about a 2 to 3% increase in their wages over time. So it's reasonable to think that for your principals, that 3% is a good target for expecting the financial performance of the business to increase, because they would then receive their share of that. If the business doesn't achieve that level of growth from year to year, the business is actually slipping backwards in real financial terms. So I hope you're following that argument. So the idea is that if it's good enough for wage earners to be receiving a 3% growth over time for their wages, it's good enough for our principals of our practices to expect a similar 3% growth in terms of their net income from year to year. Let's look at this first scenario on the screen. What we've done is considered the long-term effect of Medicare indexation. So assuming Medicare continued to exist, running at 2% for a GP who currently earns patient fees of about $400,000. And So that's $400,000 indicated in the first year. And the share of the cost for running the practice is, say, 35%, which would mean that expenses are around the $140,000 in the first year. This equates to a net income position of $260,000. We've based these figures on what an average GP could expect to earn. It's just an example for you, and you can apply these same principles against what your GPs in your practice actually earn and what your expenses are. But in principle, the doctor is earning $400,000. They pay about 35% in fees, and so they're generating income of $260,000. So looking at the chart there, whilst the Medicare rebate is historically running at 2%, it's important to note that practice expenses are also historically increasing at a higher rate at 3% each year, equivalent to inflation. So our expenses in a practice continue to rise. The medical supplies, insurances, computer expenses, wages, rent, etc. And we know that they're rising at least an average of 3% each year, and some of them more. The slide, however, is deceptive, because if you look at it, it shows that there is greater growth, a steeper growth in the revenue at 2% than actually in the expenditure at 3%. And that's because the revenue base is larger than the expense base. And by that I mean 2% of 400,000 is more than 3% of 140,000. So the degree of a degree of growth is actually achieved. So the difference over time, over that 10-year period, you would achieve some growth. Unfortunately, we've estimated that growth to be along the lines of about 1.4 to 1.5% annually. So instead of achieving a 3% target of growth, if you relied totally on Medicare indexation, you're really only achieving a 1.4 to 1.5% growth annually. In the same scenario, we consider the income over a 10-year period. So on this slide, we're based on the GP earning $400,000 of fees. You'll see that the blue line shows the positive growth income of 1.4 to 1.5% annually. Obviously, taking into account the growth in expenditure that we talked about on the previous slide. The net return of 1.4 to 1.5% is not adequate to keep up with an expected minimum net growth, as I spoke before, of 3% per annum. Over a number of years, this return of income obviously has a compounding effect in real terms. So in this example, in dollar terms, the cumulative gap between the two lines there over a 10-year period is $205,000 of net income. This example demonstrates that in the real cost of Medicare, if Medicare continued to be indexed at historical rates of 2%, that's what the real cost would be. If practices maintained 100% bulk billing or didn't increase their fees otherwise, we've calculated that there would be a $200,000 plus deficit from what would be considered to be a reasonable growth rate of 3%. So the clear message is that prior to the Medicare freeze, practices that bulk billed 100% had a flawed business model, and that it's not sustainable in the long term. I hope everyone's feeling overjoyed with all this news, because now we'll look at the impact of the indexation freeze. We know that the rates will be frozen until July 2018. So that's really a period of three consecutive years of of no indexation. And I think you might also remember that between November 2013 2014 we also had an 8-month delay in the indexation at that time. This chart demonstrates that the fee base with the freeze is going to flatline. So income is flatlined, and it assumes that patient numbers are the same and there's no change in pricing policy. Obviously the expenses are increasing at 3%. So over a 10-year period you can see that the gap between the income and expenses is closing. So it makes sense that if revenue's flatlined, expenses are increasing, then profit will decline. This chart provides a more stark reality of the actual effect of the Medicare, freezing the Medicare rebates. Assuming stable patient numbers and no change in pricing policy, we estimate that the net income in this scenario would not keep up with the historical rates of inflation, but would actually contract by 1.6 to 2.4% per annum. So what that means is instead of getting growth of 1.4 to 1.5 as we previously got with Medicare indexation, in real terms we would have contraction by 1.6 to 2.4% per annum. If expenses continue to increase at 3%, the total income is frozen for the next 3 years. The cumulative effect of the gap between the top two lines over that 3-year period is a significant $73,450. So this is based on a single doctor earning $400,000. So over that 3-year freeze period, we estimate the impact to be over $70,000. Now, we're not expecting the freeze to continue on for 10 years, but we've extended the chart out over that 10 years period to show you that if it was to continue for that time, because of the cumulative effect of that compounding each year, the actual impact after 10 years would be a massive $585,000 of net income. So we can see that the impact of the Medicare freezing is potentially significant. For the next 3 years, we're at least estimating for an average GP that impact is going to be about the $70,000 mark if practices don't do something about their fees to compensate for that. So what we've done today and through today's webinar is really to highlight the potential financial consequences of the Medicare freeze, and hopefully to demonstrate that the high rates of bulk billing nationally are not sustainable for private medical practices. I'm going to leave it to you to mull over the daunting realities of this information for now, and for next week we're going to consider some of the strategies for how practices can respond to this challenge in terms of fee setting, and also looking at creating more sustainable models of practice. So today I've gone through sorry, that's the completion of what we've got today for the webinar. So I've certainly got some time. I've got about 7 minutes here for any questions that anyone might have. If you'd like to type in any questions into the chat section there. I know I've gone over quite a lot and a lot of figures and numbers, so if you've got any questions on your mind, it would be good to open them up now.
No, it's black and white. It's black and white twice. What really, instead of having more and more doctors, I think good quality doctors and good quality patients.
Well, thanks for that, Danny. It's Sonia speaking.
Thanks, Sonia.
That was very, very informative indeed. It's somewhat worrying, to say the least, of what's going to happen with practices for the next few years, that's for sure. It hasn't been the plainest of sailing with technology today, unfortunately, but I'm sure we've all got the gist of your message. And most personally, it's just really looking forward to next week as well to carry on. If there's anybody who's got any questions, please, you know, you can speak up because I've unmuted everybody, so you can actually talk now. So delve in while you can. We haven't got Danny for long, so make the most of him, so to speak. I don't think anyone's asking any questions, or maybe they're too shy to, but by all means.
Please do ask some questions. If there's anything that that you're wondering about, it's good to ask that now. If later on in the week you do come up with a question, you can certainly probably send that through to Sonia, and we can potentially deal with that at the beginning of next week's webinar. Absolutely. But is there anything anyone's wondering about this? I'm happy to take in other questions on related topics or otherwise, while we've got 5 minutes or so.
I don't think
no,
so.
That's all right.
Okay. So I'm just. I think we'll leave it there then, Danny. I found it very, very interesting indeed. So, and I hope everyone else did as well. And we'll meet up same time, same place next week.
Great. Thank you very much, everyone.
Thanks, Danny. Thank you, everybody.